So what we're finding in general is our studies of sleep apnea as measured by the apnea-hypopnea index or other traits using polysomnography are underpowered. Of course, it takes a lot of participants to build the power for a full GWAS. So one of the obvious strategies that we can take is to look at electronic healthcare records in terms of understanding if people are diagnosed with obstructive sleep apnea or central sleep apnea even, yes or no in a crude phenotype. Now, this provides many opportunities for increasing power. A lot of large biobanks already have genotyping already performed, and there's phenotyping already performed. So there's a lot of advantages to this. The challenge is understanding, how do we relate these, clinical diagnoses, these clinical databases to research, because these are billing codes, and the billing codes may or may not, mean that you truly have sleep apnea. So what we're trying to do is do chart reviews and look for ICSD criteria. Do these people truly have sleep apnea, or did they have a billing code for sleep apnea just because they wanted to have a polysomnography test? And if that's the case, they're actually a control. So we want to make sure that we're grabbing the right people and we have appropriate classification of cases and controls. But when you do this in an EHR data, many different phenotypes have imperfect precision in terms of the coding, yes, that they have sleep apnea, or in the case of our colleagues, rheumatoid arthritis is a good example. So RA, when you code this with an ICD code, it actually really has very poor performance. So you want to grab other aspects of the electronic health record to actually improve your phenotyping. So what we did in our case for sleep apnea is we did natural language processing of clinical notes for all the patients who are cases and controls for sleep apnea. In this case, we want to improve the accuracy of phenotyping for our cases, where we look at phrases that are common to sleep apnea. For example, continuous positive airway pressure. Other aspects of the healthcare record that are common as measured in different internet sources that describe sleep apnea. So we're looking for a subset of these phrases that we find in clinical notes that ideally we can generalize to other populations because they're relatively close to what we understand as a field for sleep apnea. So we found that if you control better for healthcare utilization, how many times a person is actually seen in the clinic, you can get better phenotyping because, for example, somebody in Boston, US, where I'm from, you could go to 3 different hospitals and we wouldn't necessarily know that you truly have sleep apnea if you're being treated for, say, diabetes in our hospital and sleep apnea in another hospital. So we're trying to understand overall healthcare utilization. We're trying to understand, do you have, yes or no, a sleep apnea, phenotype ICD diagnosis, and we group these together in what are known as phe codes. And then on top of that, do you have other things in your clinical notes that can kind of boost the power? So what we ended up doing is looking at the people who truly have sleep apnea and those that were diagnosed with sleep apnea but don't have sleep apnea based on ICSD-3 criteria, and we did chart reviews for that. And we compared the true cases and the false cases, and what are the differences in their natural language processing clinical notes. And these are coded phrases where we have things through bioinformatics. And we found that, in fact, aspects of CPAP, which is obviously, as you're well aware, a common treatment for sleep apnea, having mentions of sleep apnea boosts the accuracy of these diagnoses. So we can go from there and say, okay, if we want to take this in a genetics, direction, which is one of our goals, is we can say of the people who we think might have sleep apnea, these are the people that we're confident of having sleep apnea. And then of the controls, we can actually even use natural language processing there, where we say, okay, there's no mention of, say, CPAP, for example, or other things related to polysomnography, and say we can define super controls, so we can really define these groups better. And if we can split these two groups better, then we can actually do well-powered studies where I think we can drive more signals. So we did that. We generated an algorithm for sleep apnea that improved the accuracy of, are the people that we consider to be cases truly cases? So this boosted the accuracy of that particular measure roughly from, I would say, 73, 74% with one ICD diagnosis to about, I would say, about 94% for people who had this algorithm with chart review in our validation subset. And we took that further and we looked at our own clinical biobank in Boston, and we compared the people who we believe have sleep apnea based on this algorithm versus 3 times matched controls, where these are people who have obesity. They have matched obesity, age, sex, and healthcare utilization, right, which is also quite important. We looked at these and we did a basic analysis looking to see whether or not these people have enrichment for certain comorbidities. And we found that sleep apnea is associated cross-sectionally and prospectively with literally hundreds of diseases that we found in this biobank. One of the advantages of working with an EHR sample is that we can ask all kinds of questions about all kinds of diseases versus typical consortia using like the other projects that I'm involved with, like Framingham Heart Study. We meta-analyzed with their data. They have limited questions that they ask, but we can ask the whole gamut of all kinds of different diseases, yes or no. And we also did limited natural language processing phenotyping for those diseases, as well. So we have a better sense of what's going on, both from a sleep apnea standpoint, but also from a comorbidity standpoint. And we find that literally hundreds of diseases are associated prospectively and incident and cross-sectionally with sleep apnea. And we believe that our future GWAS for sleep apnea will not only help patients and devise new treatments, but it also may limit the risks of developing some of these other comorbidities that we found. It rises with age, and we need to understand the phenotyping of sleep apnea a bit more precisely. Does somebody who is, say, a more elderly individual, say in their 70s, who has a high apnea-hypopnea index, does that mean the same thing as, say, a non-obese person in, say, their 30s that also has sleep apnea? And so if you're driving this with age, those groups may or may not have the same comorbidity profiles as somebody who's been exposed to sleep apnea for decades.